I've got 12:30. We've got lots of more great presentations. So let's go ahead and resume with part 2 of our general session. We'll have Dr. Lambert moderate. The theme here is state of the science and ongoing developments. And let me just introduce Dr. Lambert. So Dr. Laura Lambert is the chair of ACPMP's Medical Advisory Board. We are truly privileged to have her in that role. She is a professor of surgery at the University of Utah, Huntsman Cancer Institute. And Dr. Lambert joined the faculty at the University of Utah in 2018, where she is now the director of the Peritoneal Malignancy Program at the Huntsman Cancer Institute and the program director for the general surgery residency. So she's always working hard, has a million mentees, I'm sure. And Dr. Lambert's also board certified in hospice and palliative medicine. So thank you so much, Dr. Lambert, for joining us today and for such a great first session. And welcome now here as moderator for part 2.
Great. Thank you very much, Deborah and ACPMP Research Foundation, again, for hosting this incredible event. I look forward to this every year. And what I really hope, what I think the most important thing is, I know people are coming seeking answers to a lot of very personal and specific questions, but and we may or may not be able to answer all those for everybody. But what I really hope is that the people who are here will get a sense that there is other people, surgeons, medical oncologists, pathologists, radiologists who are dedicated to treating this disease and taking care of the people and their families who are dealing with it, and really trying to keep pushing the science and moving things forward, and that you're not alone, that there's really a whole group of people who are out there trying to support you and do everything that we can to cure this disease ultimately. And so I love to give this talk. It's really a great opportunity for me to go through the literature, what's coming, and get a sense of how far we've come and where we're headed. So without any further ado, I'm going to jump right in here, and hopefully I can get this to on my computer. I think I might need help with advancing the slides. Oh, there we go. So every year I look back through what's called PubMed and look to see how many publications have been published over the year in appendiceal cancer and Pseudomyxoma peritonei. And what you can see here is that while we did hit a peak a few years ago, the trend has still been pretty high. Last year, there were 273 publications dedicated to appendiceal cancer, and we're projected in 2023 to get a little bit higher than that, up to 290. And for Pseudomyxoma, there were 125 last year, and we're projected to be a little bit higher than that, getting up to 130. So the research is still coming. It's happening at a high level. But what's really interesting to see, I think, is that it's happening not only at a high level, but getting published in really high impact journals that we haven't necessarily seen before. And so a couple of the highlights that I just want to, big overview that I saw in looking through the literature this year, with that there were a lot fewer case reports. I think, we're getting to a point now where we have a greater understanding and body of knowledge around this disease, that it's when people put out case reports, it's usually about something that's unique, very rare. And while these tumors are certainly very rare, there's enough data and experience now with this tumor that we're seeing fewer and fewer case reports as people are becoming more and more familiar and aware of the disease process. As I mentioned, we're seeing more publications in really high impact journals, and that's important because it's reaching a broader audience, and it's in journals that people really respect the publications that are there, and realize when it's in that journal, it's like, wow, this is something we need to be paying attention to. Seeing a lot more around medical oncology, and a lot of this is due to Dr. Shen's efforts and the folks at MD Anderson, but others in other institutions as well, University of Pittsburgh, Wake Forest. So that's great to see that people are really starting to think outside the box, and this is not just colon cancer. We shouldn't be just treating it that way. Seeing a lot still on the genomic, so looking at the actual mutations that occur in the tumors and how that drives the biology and how we should be thinking about treating these tumors. Starting to see a lot more around genetics, and we're going to hear more about that later in this session. And remarkably, it's 2023 and we're still talking about appendicitis, but that's not a bad thing, right? Because it's increasing awareness of the possibility of appendiceal tumors and cancers as well. So I think that's a good thing. And we're going to talk about a few of these topics here. So this is an old slide that I've shown before, but I really want, this actually came up in some of the live Q&A today. So I just want to go back to that the incidence of neoplasms in the appendix for something that we call complex appendicitis has been reported as high as 30% in a couple of studies. And that is significant because as somebody put in the Q&A, the live Q&A, that there's this emphasis or question about using antibiotics to treat appendicitis. And if we do that, obviously there's a concern that we could miss tumors that are there when people should have their appendix taken out to ensure that there isn't a tumor if they get appendicitis. And so this is a study that came out in 2020. This was a really large randomized trial comparing antibiotics with surgical appendectomy for appendicitis. Now, what's important in this study was that this was not what we call complex appendicitis, where there was a large abscess or a lot of inflammation and swelling around the appendix that would make it difficult to take out, which is a setting in which we really routinely use antibiotics in anticipation of taking out the appendix at a later time. This was looking at truly straightforward garden variety acute appendicitis. People coming in would normally get an appendectomy, and the question is, could it be treated safely with antibiotics? This trial also evolved around the time of COVID, when a lot of hospitals were, their resources were being diverted to treating patients with COVID. And so it became an opportunity, if you will, to really test this theory about using antibiotics versus surgery. And what the authors of this study found was that they looked at over 1,500 patients with uncomplicated appendicitis, divided them half and half between getting an appendectomy and antibiotics. They found that people who were treated with antibiotics, this was a non-inferior, the outcome was non-inferior based on a quality of life index, but about 30% went on to have an appendectomy within the first 90 days. They also noted that patients tend to have a higher rate of complications who were treated with antibiotics, and that patients with an appendicalith, which is like a stone that's in the appendix, probably contributing to the appendicitis, were at higher risk of needing an appendectomy or having a complication. So good information that people can probably be safely managed with antibiotics. People weren't dying or going on to get critically ill, but a lot of people still had to go on and have their appendix removed because they would get appendicitis again. And there were some findings that were helpful to determine which patients might benefit from antibiotics more than others. But again, the question comes up, is there a risk of appendiceal cancer or tumor in patients with uncomplicated appendicitis? And are antibiotics really safe from that standpoint? And the group that did that original study that I just showed that was published in the New England Journal of Medicine recently came out with a secondary analysis looking specifically at the incidence of appendiceal neoplasms in the patients who were treated with antibiotics. And what they found was that out of over 2,000 patients, only 12 of them actually ended up having a tumor at the time that they ended up having their appendectomy. And so that was a 0.6% incidence. The mean age was around 46%. It was split 50-50 between men and women. And there were almost split equally between the appendectomy group and the antibiotic group. So obviously in the antibiotic group, these were people who went on to have an appendectomy. These are the tumor types that they found. So neuroendocrine was the most common. I think there were some questions in the chat about neuroendocrine tumors. Lamin was the second most common. A benign tumor or growth, an adenoma was found in 2, and 2 adenocarcinomas were found. So a relatively low incidence. But at the same time this year, as we've talked about before in this session, there does appear to be a correlation between age and the incidence of appendiceal tumors. And this is a study that actually came out of Turkey, looking at describing the high incidence of appendiceal neoplasms in elderly patients. Again, addressing this concern as we're trending towards a non-surgical treatment for appendicitis. And what they found was, in looking back over 22,000 appendectomies, that there was a 1.5% incidence with tumors, but significantly higher in people over the age of 70, almost 10% in that group. And they also looked specifically at the appendiceal diameter. So an appendix that was approaching a 1 centimeter diameter was also more likely to be associated with a tumor. So they advised caution that the one size does not fit all. And if we're thinking about managing appendicitis non-operatively, we need to be cautious about which groups we're specifically offering that to. And then in addition, last year, this was Dr. Carr, who was with us on the first session, and his group in the UK looked at the concept of the appendiceal mucocele. So a mucocele is generally considered dilation of the appendix, and the appendix is filled with mucin, and we most often associate that with a low-grade mucinous neoplasm or some tumor that is causing blockage of the appendix. It's not draining normally, and it gets swollen and filled with mucin. And in this paper, they looked at the true incidence of tumors associated with appendiceal mucoceles. So they looked at all patients that were referred to them for an appendiceal tumor. They looked at all the radiology imaging. There were 213 they identified as fluid-filled appendixes. They reviewed the local pathology report, local radiology reports, and they found that 33, about 16% of the CT scans were misinterpreted as other pathology, or there was no comment about the appendix at all. But when these appendixes were removed, what they found were that there were tumors involving nearly all of them. Only 3 of them did not have a tumor, and you can see the breakdown of the different types of tumors there. The picture on the left shows what a large appendiceal mucocele looks like. It's this fluid-filled structure in the right lower quadrant filling the appendix. And so their recommendation is that we be more specific, that when we see these appendiceal mucoceles, that the radiologists are more specifically stating that this is likely a mucinous, an appendiceal neoplasm, to get people aware, increase awareness, and make sure people are getting the appropriate treatment that they need, and that it's not just something that can be ignored. And now switching gears a little bit, again, one of the hot topics this year was molecular genomics, and we're going to be hearing from Dr. Foote, who's the lead author on this paper that was published in the Journal of Clinical Oncology, and Dr. Shen referred to this as well. This is a really elegant paper looking at the molecular classification of appendiceal adenocarcinomas, and since we're going to be hearing from Dr. Foote, I'm not going to elaborate too much, but just kind of hit the highlights. Again, really emphasizing that this was published in a high-impact journal. The Journal of Clinical Oncology is read by medical oncologists, surgical oncologists, and when an article appears in that journal, people take notice. So this was looking at something we call next-generation sequencing, which is looking at mutations within the tumor cells themselves. They reviewed over 160 mucinous appendiceal adenocarcinomas, and they identified 4 molecular subtypes or patterns that are listed here: RAS mutant predominant, GNAS mutant predominant, TP53 mutant predominant, and what they call triple negative, where they didn't see these combinations. And they found that these subtypes correlated with survival. They correlated with clinical behavior, meaning how did they respond to chemotherapy. And the authors concluded that this may be a better way to make treatment recommendations. And again, we're going to be hearing from Dr. Foote more about this. But this is really exciting because we do the best we can with how things look on imaging, how they look under the microscope. You've seen all those slides today from Dr. Carr and Dr. Leonard, but that only gives us, an impression of what's actually going on. And what's really driving the machinery of these cells is at the genetic level. So this is really important and is hopefully going to help us come up with better treatment plans for people and better understand the biology of these tumors. And similarly, a publication from University of Pittsburgh showed looked at what they called targeted next generation sequencing that improves prognostication in patients with appendiceal cancers and tumors and pseudomyxoma. They looked at over 180 patients. Again, these are mucinous neoplasms of the appendix with peritoneal dissemination. By doing targeted next generation sequencing, they were specifically looking at certain mutations. Similar to the other study, they looked at the TP53, something called SMAD4, ATM, mTOR, and the CDKN2A mutations. And what they found was that the impact of the genomic alterations in these genes was independent of grade of the tumor. Again, that's what the pathologists look at when they're looking under the microscope. The PCI, which was the extent of tumor that was present, the completeness of cytoreduction, the ability of the surgeon to get all of the tumor out, and the use of HIPEC. And so again, the graph in the lower right-hand part of the slide shows that if these genomic alterations are present, that the survival is lower than if they are not. And so again, just emphasizing what we already know, but what we're finding more out about more is the importance of understanding the tumor biology to better guide our treatment of these cancers. Another question that came up both in the pre-submission was about the clinical significance of using tumor markers, CEA, CA19-9, and CA125 in the management of these tumors. This again is from Dr. Shen's group at the MD Anderson Cancer Center. So for those of you who don't know, tumor markers are proteins that can be detected in the blood that are secreted by tumor cells that can help us monitor whether a tumor has come back, whether a tumor is progressing, whether a tumor is responding to chemotherapy. And so it's a way that that helps us monitor progression, response, and recurrence of these cancers. And what they looked at over 1,300 patients with a mean age of about 57 years. And what they found was that these tumor markers do correlate with survival. So an elevated tumor marker was associated with survival, and that the level of the tumor marker, so just whether it was elevated or not, was significant. And also the actual absolute level of the tumor markers were also associated with survival, which is a question that I think we've had that their data is giving us an answer to. Also, the number of elevated tumor markers. So if there's one, if there's 3 or 2, it impacts survival more than just one. And they found that the tumor grade was not associated with the CEA or the CA19-9, but that the CA125 was associated with a higher grade, and that the KRAS and NRAS mutations, which you've been hearing about today, were associated with an increased CEA and CA19-9. And they concluded that these tumor markers are indeed helpful, which I think most people are still using them, but it gives us a little bit more insight in how we can potentially interpret and use them to guide treatment going forward. So I just want to wrap up a little bit. So this was an invited commentary that I was asked to provide in the Journal of the American College of Surgeons. And it just emphasizes, again, the need to be aware of the appendix and the significance that tumors or cancers that occur there. At the end of my commentary, I stated that, because of its diminutive size, lack of essential function, and usually easy removal, serious concerns about the appendix are often dismissed. However, despite the seemingly insignificance of this organ, tumors and cancers that arise in the appendix are devastating and life-threatening, and once spread through the abdomen or the peritoneum require some of the most morbid surgical and oncologic interventions available. As a rare tumor, cancer of the appendix is not often considered in the differential diagnosis of acute appendicitis, but with the rising incidence, as been demonstrated by many publications, our awareness of this easily treatable, potentially life-threatening condition needs to be addressed as well. And so that's just to follow on to raising awareness, which is obviously one of the primary missions of the ACPMP Research Foundation. And I just want to end with another quote by Dr. Blake Cady, who is a legend in surgical oncology, who unfortunately passed away in July. And he stated, and is quoted as saying, the biology, when you're dealing with cancers, biology is king, selection of cases for surgical oncologists is the queen, and the technical details of surgical procedures, combined with the cytotoxicity of chemotherapy, I added that, are the princes and princesses of the realm who frequently try to overthrow the powerful forces of the king and queen. And what we really need to do and what we're trying to accomplish here today is add more of those princes and princesses through advancing our understanding of the biology, bringing in immunotherapy, bringing in other, understanding these molecular subtypes, and just increasing that armamentarium that we have to understand the king and overthrow them. Sorry, going backwards here. So what's coming in 2024? Well, you heard from Dr. Levine. Hopefully, Bromac will get here before the end of 2024. We heard a little bit from Dr. Shen. Very excited about looking forward to hearing more about the paclitaxel-based therapy. We really need another quiver in our arrow in our quiver. Genetics that are coming, we're going to hear about that a little bit later. And obviously increased awareness and prevention, and hopefully ACPMP will be back at the American College of Surgeons again in 2024. They had a lot of traffic and interest, and really were there just raising awareness about this disease and the treatments that are coming. And so with that, I'm going to end my comments. And again, hope that by participating in this and through the efforts of the ACPMP Research Foundation and all the people who are here, that you feel supported and know that people are really trying to have an impact on this disease and improve things for everybody. And so it's my pleasure now to introduce Dr. Maduekwe from the Medical College of Wisconsin. Dr. Maduekwe is a HIPEC surgeon there, and she is going to giving us an update from the PSOGI meeting, which stands for the Peritoneal Surface Oncology Group International Conference that was just held in Venice, and we look forward to hearing those updates. Thank you, Dr. Maduekwe.
Thank you, Dr. Lambert. There are some questions in the chat. I'm sorry I missed the beginning. Do we address them now or later?
No, we're trying to address them as we're rolling through. So you can just give your presentation, and we'll be working on those.
Great. Well, thank you to the ACPMP for this opportunity to present and to tell y'all a little bit about what I learned and what I found as interesting at the PSOGI International Conference. I have no disclosures that are relevant to this topic, but I do have to start by thanking all of the members of the regional therapies team who covered for me to make it possible for me to make the daunting journey to Venice, Italy for the meeting. So as Dr. Lambert just gave a presentation, I noticed that there's going to be variations on a theme, which is exciting because it feels to me like we're probably getting enough volume for several things. So again, for everyone's awareness, right, we utilize cytoreductive surgery to eradicate macroscopic disease, hyperthermia to enhance tumor cytotoxicity, and then the intraperitoneal chemotherapy as well to eradicate microscopic disease. That is the premise that we operate on as we take care of patients with appendiceal disease and pseudomyxoma. So this is what the marketing for the PSOGI meeting was. And I think that we've come a long way and we have a long way to go. Again, speaks to what you just said, Dr. Lambert, about how far we've come, but how much more work there is to do. But what was really exciting to me at this meeting was looking at all of the places where there are upcoming advances in how we take care of patients in this. I wanted to put this up to just acknowledge the very, very able steering committee and just acknowledge how wonderful the slate of talks were. It was the other reason why I thought it was very interesting and emblematic of how much progress is being made in this space is there were too many things to go to. So I could not attend all of the sessions that I wanted to because there were so many advances being discussed, which I think is a good thing. The first session that I wanted to highlight was, again, at PSOGI, there was a consensus session focused on using a Delphi consensus method to have experts across the world come together to, again, try to standardize how we take care of patients with Pseudomyxoma peritonei. So it was led by Dr. Kusumara from Milan, who reiterated the procedure for the use of for the Delphi consensus specific to Pseudomyxoma, and then gave us the outcomes of their discussions. The first 4 clinical questions were framed, and then recommendations were made. And the first clinical recommendation was whether or not HIPEC in PMP after cytoreductive surgery is indicated, just HIPEC in general, as an option to no HIPEC in patients after we account for their likely overall survival, quality of life, severe mortality, and 30 and 90-day mortality. And even though the evidence is low, the strength of the evidence is low, the strength of the recommendation was really high, with 84% of the people participating in the consensus really affirming this recommendation. For the next question that was framed was about the use of oxaliplatin in appendiceal PMP patients. And that recommendation was to not perform HIPEC with oxaliplatin in patients with appendiceal PMP, as opposed to not doing HIPEC. And it was weak. It was a weak negative, with 52% of the people involved in the consensus agreeing. The next 2 were about leaving space and room for areas that we need more interrogation, which is that for patients with appendiceal PMP, you could perform HIPEC with cisplatin and mitomycin C, or with high-dose mitomycin C regimens could be performed in those patients, and those were weakly positive. Nothing was quite as strong as just the general understanding and agreement that HIPEC should be performed in PMP. When we start targeting the specifics of how we perform the HIPEC and what we should perform the HIPEC with, that's when we get into some of this disagreements. And then the final was focused on which regimen to focus on. And so the final question was, should we perform HIPEC with oxaliplatin in PMP after cytoreduction as an option for patients with severe morbidity and considering quality of life? And it was said it could be performed, again, a weakly positive, but more positive than the interim ones. There was also a research recommendation, which is informed by the consensus, right? The reason why we use a consensus is not to close off. There were some concerns. There were some concerns raised about the use of the consensus to stifle ongoing clinical research and ongoing research attempts. And that is not the goal. The goal is to standardize and try to standardize how we do HIPEC across the world. But it then informed the recommendation for research, which was that a high quality, and 39.4% of the people involved thought that a high quality would mean using a randomized design study should be performed comparing cytoreductive surgery and HIPEC to cytoreductive surgery alone in patients with PMP. And the preferred regimens to be studied were going to be cisplatin and mitomycin C, or mitomycin C alone. So that was how we started out today, talking about appendiceal PMP. And then the next session was focused on appendiceal neoplasms and PMP. And I will say that this was a really, really riveting session. And I do want to highlight that just from listening to Dr. Lambert's talk, that there are areas of overlap. So it's good to see again and affirm that a lot of the work that's being done across the world is in synchronicity, and that we are interrogating the same things and coming to similar findings, and that will be a way for us to go further faster. So Dr. Smolenchi gave a presentation that was about the role of medical therapy in PMP, which I will not focus on here just for time, but I thought she did a really beautiful job of grounding us in what we know about PMP, that I think sometimes when we spend a lot of time taking care of patients and focusing on the specifics, we do not refer back to, which is that PMP, of all of the people we take care of with peritoneal disease, has really, really great outcomes, right? When we look at this graph, I don't know if you can see my pointer, but when we look at this graph, we see that the blue line, which is at the top of the Kaplan-Meier curves, is the outcomes in patients with Pseudomyxoma peritonei. And if we look at this National Registry of Spanish patients who had peritoneal oncology, of the 4,159 patients who had these interventions, about 508 of them were patients with PMP. And in those patients, there was severe morbidity in almost 20% of the cases, a 13% reoperative rate, but the disease-free survival, median disease-free survival was 68 months, and the median overall survival was not reached. It was 5 years overall survival of 74%, which is what we know. And then when we zoom in on PMP specifically, and we think about the different grades, again, we know that there's recent data reaffirming what we know, that grade matters, right? If folks have lower grade disease, they do better than patients with high grade disease, and those patients do better than people with high grade and signet ring cells. Dr. Swansea went on to talk about medical therapy and immunotherapy, gene therapy, and I'm not going to focus on that given our time limitations, but I thought that was just a really great place to focus us in. Dr. Ma from the Aerospace Center in Beijing, which is the clinical teaching hospital of Peking University, which not only serves astronauts and coworkers, which I think is really cool, but also serves regular folk across the country, but is the only hospital in China with a PMP department. Also gave us a talk about their work looking at prognosis conferred by molecular features of appendix-derived PMP. And looking at their case volume is particularly impressive, right? The number of surgical procedures for PMP over the years. In 2022, they did 215 cases in just this one hospital. So they're a great place to be able to do really focused work on looking at the tumor biology. And so they did this study where they looked at 81 patients with appendiceal PMP with various histological subtypes, and did next-gen sequencing and whole exome sequencing to identify mutational signatures, look at signal pathways, to look at molecular features, to figure out if there are particular associations with prognostic factors. And what was impressive to me, the median PCI in their group was more than 30. So patients who are generally sicker than, who have a fair amount of disease, and they were able to look at the median tumor markers. What I want to focus on, and I'm sorry this slide is blurry, but really what I found really interesting in this was they did identify 19 mutational signatures, and were able to start seeing a difference in the distribution of signatures between low-grade PMP and high-grade PMP. They have other work ongoing and will be presenting and publishing their data soon. But I thought that this was really interesting as someone who takes care of PMP patients, and I'm sure the reason why ACPMP exists, sometimes feel a little bit left behind when we're talking about gene therapy and immune therapy for other solid organ tumors. So seeing progress in this space was really exciting for me. And then Bromac, I see Dr. Levine on the call. And so he and I have already talked about Bromac, and I was really, really interested in listening to Dr. Sanchez's talk about the work that they're doing in Spain at their center, taking care of patients with recurrent and unresectable pseudomyxoma. So to go back and recite us on exactly what Bromac is a diminutive for bromelain, which comes from pineapples, which I always find very interesting, that contains enzymes that dissolve the hydrolytic bonds in mucin. And then the AC is from N-acetylcysteine, which has a mycolytic effect and reduces the formation of the disulfide bridge is in mucin. So they work together and synergistically to basically dissolve and break apart the mucin. Why do we care? Well, there is data from, if I can make my slides, there we go. Oh no. There is data on the use of Bromac in patients with peritoneal mucinous tumors in this series of patients, 20 patients who received this therapy over a year, with 73% tumor objective response rate in the tumors. And since then, there's been a lot of excitement, as we know, of how to implement this and who should implement this. And so listening to Dr. Ahona Sanchez's talk about their outcomes was really particularly exciting to me. So what did they do? They gave bromelain and N-acetylcysteine into the tumors after calculating the tumor volume for 3 consecutive days. Their primary endpoints were the objective tumor response rate, toxicity, and side effects, because there's a lot of concern about injecting novel substances into patients in whom we don't have access to their abdominal cavity. And they also focused on the secondary endpoints, such as quality of life, progression-free survival, and overall survival. The primary endpoints are coming through. The inclusion criteria were adhered to, a CAT scan to help place the catheter. And again, injections were done over 3 days, and they did quality of life questionnaires and surveys prior to and after the administration. And their results are fairly impressive. So we see in blue the patients who are having their tumor, who had a partial response stabilization, and a couple of patients who had tumor progression. But most of their patients, 54% had a partial response and 27% with stabilization of their tumor. And at 1 year, even better responses. So 66% had a partial response, 12% had stabilization, and 12% had tumor progression. And the patients did pretty well. No major adverse events. 75% of the patients had fevers during their treatment, but they did pretty well afterwards. And the conclusion from that was that the use of Bromac was safe, has shown a benefit. There was improved quality of life, which I think is really important in this patient population. It's one of the things that brings patients to us, right, is their symptoms. So having improved quality of life just 1 month after the application, I found impressive. And then being able to maintain that for 1 year after treatment. And noting that larger multi-center phase 2 trials are ongoing. And Dr. Ahona Sanchez also spoke a little bit about being intentional about tumor patient selection, and so looking at shear elastography to evaluate the mucin would maybe improve the selection of which patients get this therapy. Perhaps it should be focused on patients with low-grade disease with soft mucin, and the elastography would be a way to characterize the softness of the mucin, as it were. And again, this is where we are, Frederick and the Medical College of Wisconsin. I want to thank the group for the opportunity to present and tell you about what I learned on my trip to Italy.
Thank you, Dr. Maduekwe. That's a great summary, and especially exciting findings about the Bromac. I think that's something that everybody, we're just all holding our breath and waiting for it to come. So wonderful. Thank you for going and sharing your insights.
Going was no hardship. So.
All right. Up next, we have Mr. Jim Carroll, who is the president of the ACPMP Research Foundation. Always look forward to hearing his updates and just celebrating the mission of this organization. Jim.
Thank you, Dr. Lambert. Appreciate it. Yeah, it's an honor today to spend a few minutes and share the story of the foundation and some of the goals. Bear with me while I change my slides. Okay. I want to start with just going over the basics. We're a nonprofit 501c3 organization. We began in 2008. And Lisa Luciano was our founder, along with Mike Dvorsky and a core group of individuals at that point in time. The mission from the very beginning was based on really two goals. One, to fund and support research to discover new treatments for appendix cancer with the hope of one day finding a cure. And number two, to fund and support educational programs for healthcare professionals and patients, caregivers, and families to keep pace with the evolving science and to increase awareness about the rare disease. All of this work is made possible by the generosity of our donors. We are extremely grateful, and no donation is too small. Every dollar matters, and every dollar makes a difference. This is our current team. It's made up of 3 board members, Judy, Deb, and myself. We are an all-volunteer board, and 2 staff members, Alyssa and Jamila. And Alyssa and Jamila have joined us in the last year. They've been very impactful to achieving our mission. Next slide, please. Thank you. We've had the benefit since inception of an outstanding medical advisory board, which is shown here. Most of these individuals have been with us for a long time. Dr. Shen is a recent addition, and the advisory board is led by Dr. Lambert. So we are very appreciative of their ongoing support, and they're critical to the success of the foundation. Our scientific advisory board shown here has been formed in the last couple of years, and their primary objective for us is to focus on our grant program. We brought the program in-house from previously using NORD, and they've began doing some outstanding work. Our hope would be in the next couple of years that we could give out more grants and a higher level of grants as well. Dr. Holowatyj is the chair of our advisory board. This slide really demonstrates what our core focus is and has been. And, it starts off with funding research. We've been able to fund at least 2 $50,000 ACPMP Catalyst research grants each year. In some years, we choose to give out additional grants. So far, since inception, we've given out 36 grants for about a little over $1.6 million. The grants support basic scientific, clinical, or translational research focused on appendix cancer and PMP. We also play a great part in funding Symposium travel scholarships, which we're very proud of. On the education and awareness end, Deb has launched this year a great monthly educational webinar series. We do a variety of symposiums like today's multi-regional symposium, and other awareness-related things are focusing on Appendix Cancer Awareness Month. One of the things that we did this year for that was the Light Up campaign. And we participate in a broad array of medical conferences for various types. Patient and physician resource and support is really, if you go onto our website, you'll see a variety of information that is really dedicated to helping patients, helping caregivers, and helping specialists get to the, and physicians getting to the information that they need about the disease. There's links to online support forums, clinical trial databases. You can use the Find a Specialist tool. There's a published research repository and a variety of patient educational resources, including new patient guides and our video library. And lastly, really the life's blood of all this is our fundraising efforts. Our fundraising efforts support all of the above and all programs and initiatives. It's really broken into 2 things: our foundation-driven fundraisers like our annual cancer walk, and our volunteer-initiated, where many of our patient families come forward and they want to contribute, and they create an event that raises funds. We also have things like social media. There's a whole range of fundraisers that all contribute to supporting these programs. Next slide, please. This is just a quick example of some of the pictures that demonstrate some of the events that we have. Recently, I would give some recognition to a couple of events that were held. We had a cornhole tournament recently in Massachusetts in honor of Rob O'Neill that was highly successful, and we were appreciative of that group. We also had the Wade Strong Cornhole Tournament in the Philadelphia area to honor Wade Wortman, which also, it's been multiple years since that's been held, and we're appreciative of that. And the Katie Santorbi Foundation had really an outstanding golf tournament this year with a lot of fun. And that tournament was out of St. Louis honoring Katie, and we're appreciative of that as well. And lastly, an A-Rod Strong kickball tournament, and which had a little trouble due to weather, but a great effort also. This just demonstrates, our basics on our Catalyst research grant and what our aims are, as I've indicated earlier. And as I said, altogether, we've given out $1.6 million in 36 research grants, and we are hoping to really impact the community by getting more aggressive with that in 2024. We're extremely optimistic on that effort. And we just want to thank everybody on this symposium today, especially you, Laura, and Dr. Levine and Dr. Turaga for leading this effort. We're highly appreciative of that. And with that, Laura, do you want to introduce Adele, or should I?
Well, maybe we can do it together.
Okay, great.
So yeah, thank you, Jim, and congratulations. You guys have done just a tremendous effort in supporting the research going forward and the education and patients. And I know people appreciate it. I don't know what we do without your group. And similarly with the PMP Pals, right? And so we have Adele Jason, who's the president of PMP Pals, and she's going to speak to us about their organization. And I will say that when I'm meeting people for the first time in clinic, and you can tell that somebody's been online, trying to find out information, there are two websites that I direct people to that I tell them I trust the people that are running them and the content that they're going to see. And it's ACPMP and it's PMP Pals. So thank you both. And Adele, take it away.
All right. Thank you, Dr. Lambert. Thank you, Jim. On behalf of PMP Pals, we appreciate the opportunity to talk about our organization, and we appreciate the collaborations we do have with ACPMP. PMP Pals is the world's oldest global volunteer-run organization, giving hope to both patients and caregivers dealing with an appendix cancer diagnosis and related conditions like PMP. We are, next slide, please. Oh, I have control. Sorry about that. We are celebrating our 25th year of existence. So for 25 years, we've been providing hope and support to patients. Many of you recognize our founder, Gabriella Graham. Without Gabriella, we wouldn't be where we are today. Gabriella was fearless in providing information, providing support. As was mentioned several times during the sessions earlier today, patients need to know they are not alone. And we're there to make sure that they know that. We're here to support them really every step of the journey. We often say the physical journey is difficult, but the emotional journey and the need for emotional resilience is not to be underestimated. And we're here real time working with patients at various stages of their journey. We have our board. Our board members are presented here on the slide. We're all volunteers, either patients or caregivers. We also have a large group of volunteer patients or caregivers that work on all of our programs and interact with the different patients and caregivers. Some of our programs, one of our most popular are our Hope Zoom calls. Twice a week, we have live meetings for anyone that would like to show up to talk about what's going on, how we can help. We learn so much from each other, and that the patient perspective is so important. We also, provide educational resources, and as part of our Hope Zoom, we do have, specialist guests that interact, with the patients and provide us with information. So we're happy to facilitate those sessions. Two of our legacy programs are what we call our Bare Bottom Bears and our Get Well and More card programs. As a patient, your world just changes when you get this diagnosis, and it's a long journey. So just knowing someone is thinking of you, supporting you, have been there, is there to guide you on the other side of treatment. We send these Bare Bottom Bears. Typically they get sent to patients preparing for surgery, but we can send them out anytime. Old school way of cards. There is nothing more hopeful than getting personal notes from patients and caregivers around the world, letting patients know we're thinking of you, we're wishing you the best, we're here for you. And we're happy to send those to anyone at any time. We're on social media. And we have one-on-one mentors. As we've evolved with our Hope Zoom calls, we've gotten to know our patient participants because we see them twice a week. But we also do a lot of one-on-one support and one-on-one mentoring, depending upon what patients' needs are and what they want. You can reach us anytime at info@PMP Pals with any questions or connections you would like us to make. You can visit our website at pmppals.net. We do have a monthly newsletter, so please sign up for that. One new program that we just launched last week is Broad Blankets. So similar to the bears in the cards, and this was inspired by a father's desire to bring comfort to his recovering daughter, and that's again just another tangible token that we are thinking of you and are here for you. Pals living life. When you're diagnosed, you can't even imagine what life is going to look like. And so we do offer opportunities and provide, tangible, disclosure of, how patients are doing as they're going through their treatments or on the other side of surgery. So that, there is that hope on living life as part of your journey. We have meetups. This was something that Gabriella did in her day. Our most recent meetup was actually last week, and we partnered with Dr. Freidart and the Medical College of Wisconsin, and you just heard Dr. Manikay's presentation. And the Zoom meetings are great, but sometimes there's just nothing better than seeing everyone in person, giving them a hug, and knowing that they're supported and we're here for each other. Here's a little summary of the impact we had. We don't have our 2023 statistics summarized yet, but in 2022, we had 9 specialist presentations. We had 95 Hope Zoom meetings touching 2,600 attendees. we sent out 35 bare-bottom bears. We had, 70 participants at our 2022 meetup. You can see we sent out, cards to 85 pals, and 1,200 people wrote cards. So, our reach is far, and our touch is great. And, what we do is, help with that emotional resilience and support. We're totally donation driven. You can find out more information on our site on how to contribute. And, we'd love to have everyone join us, register for our Zoom meetings, sign up for our newsletter, follow us on Facebook, Instagram, get involved, always looking for volunteers and help. So in a nutshell, that is my overview of PMP Pals, but, we appreciate what everyone on this presentation does for us as patients. And, we're here to continue to make sure patients are not alone, and that the specialist group knows we're here for your patients.
Great. Thank you, Adele. And thank you for all your efforts over the years. It's been great to work with you as well. So yeah.
Thank you.
All right. Next up, we have Dr. Kiran Turaga, who's the chief of the Division of Surgical Oncology at the Yale School of Medicine and one of the co-hosts of the meeting here today, and just an outstanding force in the world of cytoreductive surgery and the management of peritoneal surface malignancies. And so Dr. Turaga is going to talk to us today about the ongoing clinical trials.
Wonderful. Thank you very much, Laura. And it's so nice to see all of you. I think Dr. Lambert mentioned this when she was making her remarks, but this is truly one of my favorite symposiums. And I think we've had the good fortune of seeing it evolve over the years, and it's so wonderful to see more science coming. But I think, when we think of clinical trials, there is this visceral response of, am I a guinea pig? Am I being experimented on? And, I remember as a young fellow about 20 years ago, I took care of a patient who unfortunately died very soon after her diagnosis of disease. And that same patient today, had she had the same cancer, would have been cured of her disease. And this is only because of, advances in research, advances in science, and advances in clinical trials. And so I wanted to speak a little bit to all of you about how do you kind of think about clinical trials? Where are they right now? How do you explore these? And then when should you participate in clinical trials? So I do consult for Merck, but it's not part of what I'm going to speak about today. So the key basics, and this is very important for all of you to kind of know and understand. And the National Cancer Institute has a lovely website, which actually goes through specifics of what are the phases of trials. There's actually a nice little infographic video. But there's three main phases of trials. There's the phase 1, which are very small studies. And really, this is the first time drugs are being taken from sort of the lab or from animal models and being brought to humans. And the purpose of a phase 1 trial is mainly to see, is it safe in humans? And so really, this is a safety trial, and also looks at the dose escalation. So essentially tries to figure out what is the right dose of giving these drugs to patients. They're very safe. And in some ways, they're not well tested, but they're sort of very exciting because these are technologies that have worked really well in models and science. And so I think it brings that sort of element of novelty, but also has this little unknown factor to it. The phase 2 trials are smaller studies, so usually less than 100 patients, and they're looking sort of at what we call efficacy. So they're looking to see, does the drug actually work? And if it does work, sort of how much does it work? And I think many trials in the space of less common cancers, like appendix cancer, will be sort of the phase 1-2 clinical trials where you're trying to explore and see, does it work? And it's hard to accrue large populations of patients, which is sort of what phase 3 trials are, which is where you take these sort of concepts and move forwards. So from a patient perspective, obviously, it's nice to be on a phase 3 trial because you know that there have been 2 steps that have gone through and you're ready for this. But at the same time, there's other factors that you should really think about when you're considering enrolling in clinical trials. So first of all, and this is not a minor consideration. It is important to think about location. Fortunately, in the United States, there are at least 51 NCI designated comprehensive cancer centers. There's numerous good institutions that have expertise in cancers. Not everyone might have the same expertise in appendix cancer, but I think location is very important to think about, because while it's, going to a place for having surgery is one thing, because it's a single time event and a single commitment. Enrolling in a clinical trial requires a much more significant commitment that lasts through the duration of the trial. So it is important to make sure that when you're thinking of a location, that it's sustainable for your family to be part of this. And I'll give you an example of why that's important. The other is to think about what kind of a trial is it? Is it a therapeutic trial or is it an observational trial? So there are trials which are enlisted on the main website. It's clinicaltrials.gov. It's run by NCI. But the observational component is where you're trying to study how populations are doing and kind of trying to make associations, as opposed to therapeutic trials where you're looking at new treatments and new interventions. So that's the important thing to think about. The third, and this is very important, talk to your oncologists and your surgeons, and certainly to ACPMP, other support groups, PMP Pals, to really think about how novel is this trial? Is this something that is very promising? Is this something that has shown dramatic results? Even if it's a very early phase trial, if it's very dramatic in sort of what it's promising to do, or is very appealing in its mechanism of action, certainly worthwhile to think about. And then finally, one thing that I would encourage all of you to think about is the world is moving away from just purely being what we call histology specific, which means it's not always appendix cancer. There may be cancers that are now KRAS G12C mutant cancers, which could be appendix, which could be lung, which could be bladder, but they're all treated with a drug that targets the mutation KRAS G12C. And so I think you're going to hear about genetics a little bit later. And it's very important for patients that have appendix tumors to know their somatic mutations. So what is the mutations that are there in their tumors? And if they've certainly been tested for hereditary mutations, to kind of learn about that, called germline mutations. So I think it's important to understand this, because that really emphasizes which trials you're eligible for. I might have lost control here. Let's see. So numerous studies have actually found that sometimes, instead of being histology specific, instead of saying, let's choose an appendix cancer trial, let's choose a mutation-driven trial, and actually have found that it may improve survival. So this is a big study that was published in one of the big journals, which found that when you actually treated patients with targeted therapies, as opposed to just being focused on the histology, patients actually did a little bit better. So when you think of the categories of trials, there is one which is sort of looking at the sequence of standard of care. So where you take normal drugs that you think work, like FOLFOX, FOLFIRI, surgery, and you say, well, let me kind of intersperse things around. Let's give FOLFOX first, then let's do surgery, then let's do more FOLFOX later, or let's do something in the reverse order. So these are more sequence trials. And while they're very important to understand what is the right way of taking care of patients, they are not promising a new therapeutic alternative to patients. The second group of trials are immunotherapy trials, cell therapy trials, and this is a basket term for many trials which are actually trying to manipulate the immune system to activate and then be able to recognize the cancers and kill them. Sometimes it requires activating your own immune system, and sometimes it's putting in foreign immune system cells like T cells or activated T cells, CAR T cells, where they're or NK cells that are being put into your body that help fight these cancers. Targeted therapies are drugs that activate and work against mutations. Viral therapies that kind of destroy, have viruses that target these cancer cells and kill them. And then, of course, surgical trials or radiation trials. And so what I'm going to discuss in the next little bit is clinical trials that are currently open and recruiting for appendix cancer. So I just used the term appendix cancer in the search term. I did not look for targeted trials. There's millions of those, but just for appendix cancer, and then I did the search. So I'm going to give you some highlights of some of the trials that are ongoing right now. So the first trial, and Dr. Rauf was kind enough to share the slide with me. This is at the City of Hope Cancer Center. And this is utilizing a technology called PIPEC. Some of you might have heard of this already. PIPEC requires a liquid medium in which chemotherapy is distributed. PIPEC is an aerosolized chemotherapy, and the premise being that aerosol kind of distributes better, like an air freshener distributes better than perhaps a liquid perfume that's put in the corner of your room. And so the premise is that maybe PIPEC will distribute the drug better. So look at this trial design with me for a little bit. And so this basically is looking at patients with unresectable. So if you can have cancer surgery, then patients are generally offered surgery. But if they have unresectable disease, those are the patients that are enrolled in the trials. You cannot have liver or lung or bone metastases, and they get 4 months of chemotherapy and cannot have a bowel obstruction. And this is a phase 1/2 trial. So essentially in the first phase, they're increasing the dose of the drug, which is mitomycin in this case. And then after doing that, patients will get PIPEC, which is basically with mitomycin. And then this will be alternating with FOLFIRI chemotherapy. So you get mitomycin, then FOLFIRI in 2 weeks, FOLFIRI in 2 weeks, then PIPEC again. And the end result is to see if patients will have a better response to this and have reduced progression-free survival. So this is the clinical trial that's open currently at City of Hope and is enrolling. The second clinical trial that's open in Ghent, Belgium, which also includes patients with appendix cancers, is a nanoliposomal irinotecan. So irinotecan is a chemotherapy agent that prevents cells from growing, essentially interferes with cell replication. And this essentially takes the drug, it's wrapped inside this sort of lipid layer that makes it, slower release. So it actually doesn't release right away. It reduces the toxicity and doesn't get absorbed as much. Again, this is a phase 1 trial, which means it's just coming to humans, and we're trying to figure out what the correct dose of this is. The next trial, which is open at the NCI, this is again a basket trial, which is open for many different cancers that spread to the peritoneum. And this uses the drug paclitaxel, which you heard Dr. Shen mention that might have some effect, that is given both intravenous and intraperitoneally, along with a tyrosine kinase inhibitor called nilotinib, which has been shown to have some efficacy in colon cancers. Where this is the trial, and Dr. Blakely was kind enough to share these slides with me. This is at the NCI in Bethesda, Maryland. And basically, this is again for patients who have unresectable disease, so cannot have surgery, cannot have cytoreductive surgery. They have a laparoscopy, they get a biopsy of the tumor, they place a catheter inside, and then patients are given the drug nilotinib as pills that you take. And so therefore, you can't have bowel obstructions to be on the trial. And then you get intraperitoneal paclitaxel and IV paclitaxel, and I'll show you that. And essentially, the end result of this study is to see if patients are able to undergo cytoreductive surgery. But this is an illustration of the study course. So if you are enrolling in a trial like this, you really would have to potentially move to Bethesda for some time, because every week you're going to get chemotherapy with paclitaxel, and every day you're taking the chemotherapy nilotinib. So it is a pretty significant undertaking for patients and families. But this study is looking to see if patients will be then downstaged such that they can have surgery called cytoreductive surgery. So that's the premise of this trial. We have a clinical trial which is open at Yale. This is, again, includes patients with appendix cancer, but not specific for patients with appendix cancer. And again, this comes up when you search on the clinicaltrials.gov, but this is looking at a different molecule that works similar to irinotecan, but is called exatecan. It works a little bit differently on that enzyme, but then it's bound to a peptide that makes it more specific. Again, this is a phase 1/2 trial, so starting at looking at dose and then kind of moves over to looking at some degree of efficacy. I think what is a very interesting concept that hopefully we'll be able to do in the United States fairly soon is chemoimmunotherapy. And this is something where chemotherapy, such as a tyrosine kinase inhibitor, is being added to an antibody, which is a novel antibody that acts in similar ways to other checkpoint inhibitors or immunotherapies, along with chemotherapy. So it's surufatinib, sinitilumab, and capecitabine that's given for patients with appendix cancer in Guangzhou It's single arm, but it's a phase 2 study. And so this would be a very interesting study as soon as it accrues to see if this combination is effective for patients. And then targeting specifically G12C, which does happen in patients with appendix cancers, where this is being combined with another chemotherapy agent, JAB 21822. And this is also an early phase trial, but this is also in Beijing. And then there are a few studies which I think are important to understand, but perhaps not as novel. One is looking at increasing the dose of 5-FU chemotherapy called dose escalation. And one of them is looking at determinants of chronic pain after cytoreductive surgery. So trying to understand more why patients get pain after this and chronic pain. And then for surgery, there is a clinical trial that is used for appendix cancer called the Live Long trial, which is surgery or radiation for oligoprogressive cancers. It's again a basket trial, includes all types of different cancers, but also includes appendix cancer at UC Davis. It's a single arm study, so it doesn't have a control. So no group where they're not doing this, and the end result is looking at disease control at 3 months. And let's see. And then ctDNA or Signatera, as some of you might have heard, or Guardant, other such tests are becoming relevant in this. The Rutgers group with Dr. Alexander is looking at a ctDNA guided therapy. This is an observational study called Pericles, where they're basically trying to see what happens to patients who get ctDNA to then understand how relevant it is to their cancer management. You heard about exercise and nutrition and prehabilitation. You'll hear more about it a later part of the sessions today. But there's a trial in Dublin looking at how important is this before surgery, and the end result is feasibility. And so, I know I've given a bunch of trials over here. I wish this portfolio of trials was much bigger. Honestly, it takes close to 20 to 30 studies to have one positive result in some of the GI cancers. And so it is important that we continue to advocate for better clinical trials and use novel and modern mechanisms of trying to understand how best we can adapt these clinical trials so we're doing effective treatments in our patient population. But I think if you ever have any questions, obviously feel free to reach out to any of us or ACPMP. We're happy to help guide you as you're thinking about clinical trials. And so we need research and we need advocacy, and thank you all for doing both.
Great. And thank you, Dr. Turaga. I love the just organizational framework about thinking about how to select a clinical trial and the different logistical aspects and practical aspects about that in the overview. And the idea of not necessarily focusing on appendiceal cancer per se, but with what we're learning about the biology of these tumors and the genomics, that will increase the number of trials that are available to people. So thank you for emphasizing that as well. Next up, moving on to genetics and genomic sequencing, another hot topic that's definitely coming up. And we have Dr. Andreana Holowatyj, who's from the Vanderbilt University Medical Center and is the chair of the ACPMP Scientific Advisory Board. And she's really become a driving force and a name in this area, and we look forward to hearing from her today. Thanks.
Thank you, Dr. Lambert, and thank you everybody for joining today. I'm super excited to be here, and to both Dr. Lambert and Turaga for teeing up a little bit of my talk very elegantly for me. And so I'll be talking to you today, and hopefully just a brief but broad overview on genetics and genomic sequencing in the context of what's it all mean, where are we at, and where are we going overall. Okay. My disclosures, I don't have any conflicts of interest for this talk. So, perhaps you last saw a figure like this when you were in your last biology class, however long ago that was. But I think to glean an important understanding of the distinction between genetic and genomic testing, kind of got to take it back to the basics first. And so genes are the instruction manuals for our body, and they're overall comprised of DNA. So as you can see, walking you through this figure from top to bottom, our body is made up of trillions of cells. Each cell is like its own tiny factory overall. And within the nuclear component of the cell, this is where all of our DNA is wound into chromosomes. So there are 46 chromosomes in the center of every cell, and we get half of those from our mother and half of those from our father, which is where the hereditary component of things come in on the genetic schema. And so a section of DNA is called a gene, and each gene has a specific job in our body. So all of these genes are passed down from our biological parents, and there are about 20,000 genes in the body that each have their own specific job. So many changes in our genes contribute to making us unique and don't cause health problems. I think that's important to contextualize and understand. A great example of that is the genes for eye color. They're whether you have brown eyes or whether you have blue eyes, they're not exactly the same, but it doesn't actually affect our vision or ability to see. So not always are they consequential in terms of our health. However, as you may anticipate for the scope of this talk, there are some genetic changes that can cause health problems. So here, kind of zoomed into the cell in that nucleus. Like I said, if you consider the nucleus kind of like a control room in the factory, not everything always works perfectly. And so perhaps the cell makes a product from a gene that doesn't work like it should. That's a genetic change, whether that product becomes the wrong size or shape, or the cell may not make that product at all. A good example of that is, let's say the factory from that cell makes basketballs, but a genetic change causes the basketball to change shape in such a way that it doesn't bounce and it's not usable. And in such a parallel, that can yield or lead to a health problem in the context of genetic changes that we may have inherited from our parents. And so how do we figure out if we have any of these genetic changes that are passed down to us or, heritable? And that's what our genetic testing comes in. So genetic testing is able to scan a set of specific genes of interest, and it can identify specific genetic change that could be causing a disease such as cancer overall. So if you undertake genetic testing, you typically get a report back overall. You take some sort of saliva or blood sample, and a test is run to sequence your DNA. So genetic testing is like a spell check of your normal DNA that you have in every cell. And I'm showing you here an example that is not a real patient. This is retrieved from the Broad's website of a report that comes back upon completion of genetic testing. And this is something walked through with a genetic counselor and with clinical care teams. So I'm not going to go into this in too much depth because each one is unique. But there can be different categories of genetic test results. A positive or an abnormal one says that there was a genetic change or variant identified. And we know that this genetic change actually increases risk for specific types of diseases. There is established evidence for that. That may yield clinical actionability and is an individual discussion with your care team. There can be a negative or normal result. Nothing was identified known to cause a particular disorder for such that, if you did a cancer of uncertain significance, it means that there's a change there, but we don't actually understand the implication or the role of that change in causing specific disease quite yet. And so that's overall the scope of genetic testing and understanding what changes in our DNA we've inherited from our parents that may be increasing our disease risk. These are things we're born with. On the flip side, and sorry about the cutoff on the understanding on the screen, you heard Dr. Turaga speak a lot about genomic sequencing and really leveraging this robust information to understand characteristics of the tumor, or taking kind of like a magic school bus dive into the tumor and understand what the DNA of the tumor looks like. This is equally as important as genetic testing. We know, and I'll briefly touch upon this shortly, we know that about 1 in every 10 appendix cancers have some sort of genetic variant. Saying they're inherited is perhaps a bit broad in interpreting. We're trying to still understand the consequence of these variants in the context of appendix cancer, But overall, in the broad cancer schema, it's between 5 and 20% across all different cancer types that are inherited. So the point of that is really to say most cancers are the results of changes in our DNA that happen over the course of our lifetime. And so understanding what DNA changes are contributing to cancer development and cancer spread throughout the body are crucial for several reasons. So genomic sequencing, and here again is an example report of what may be derived. This is, again, not a real patient. This is an example provided on the Tempus website. But genomic sequencing scans the tumor DNA to perform a spell check to identify what DNA changes in the tumor can be potentially targeted with drugs overall. Like Dr. Turaga said, the KRAS G12C overall, that's actually the example on the screen here that was provided in this report, yielding potential actionability where there may be a targeted treatment that we know could have benefit. Equally, on the flip side, presence or absence of a change in the DNA in the tumor may also tell us that a therapy is likely not to work, which helps us prevent some serious side effects or a treatment possibly not being able to respond to that treatment. So genome sequencing and scanning the tumor DNA really provides us with a wealth of information about both the behavior and development of a particular cancer type. So I kind of wanted to just summarize everything I said in one slide to give a direct comparison in terms of genetic testing versus genomic sequencing. On the genetic side, this is our normal DNA. We're looking for single gene changes in our normal cell that we inherited from either mom or dad. And genetic testing helps us predict risk for the development of certain cancer types based on the evidence that we have and what we know may contribute to increasing cancer risk. And this is important because understanding that genetic risk for cancer may impact screening or surveillance. It may impact family members getting tested or identifying a hereditary cancer syndrome as well. And on the genomic side, we're doing a spell check on our tumor DNA, utilizing either the tumor or potentially a blood sample to look for these DNA changes across our lifetime that we find to happen in the tumor cells. This helps us predict how the cancer may grow and identify vulnerabilities in the tumor that we can potentially exploit through specific therapies. And that is actionable to determine whether some therapies might be an option to consider for cancer treatment. So a question that I think is hot off the press or hot in debate at the moment is genetic testing relevant in appendix cancer? I lean on the side of yes. My team was recently the first to look at the prevalence spectrum of genetic variants in appendix cancer and found that 1 in every 10 patients with appendix cancer harbors at least one genetic change in a gene that we know increases your risk for developing specific types of cancers. This is important because cascade testing, which means testing of blood-related family members, and genetic counseling for those individuals who may be at risk of a potential hereditary cancer, has the opportunity to direct potentially life-saving cancer prevention and surveillance strategies. Second, understanding genetic risk for developing other types of cancers. So if you present with a genetic change that we may not know yet, whether that increased risk of developing appendix cancer, but it would change the practice for how we surveil for other cancer types, that's really important to consider overall and from a cancer prevention perspective. And then we have substantial efforts underway to deepen our understanding of what those genetic changes are that increase appendix cancer risk, and most importantly, what we call their causality, understanding that there are this broad spectrum and pretty high prevalence of inherited genetic changes in appendix cancer patients is one piece. But the second piece of that is understanding how they actually develop how they may impact the development of the tumor itself. So really 2 areas of key focus in discovering new genes that may be associated with appendix cancer risk that are not yet included in current genetic tests. So there's something unique to appendix cancer that we don't just know about yet overall. And studying the impact of these genetic changes in appendix tumor tissues is, of course, critical from that causality piece. So a question we often get is, I'm interested in genetic testing. How do I go about this? Of course, I don't endorse any specific tool, but I can say NCI designated comprehensive cancer centers, Vanderbilt, Huntsman, Wake Forest, Yale, all have genetic counselors who specialize in cancer and are able to provide this support. There are Find a Genetics Clinic tool from the American College of Medical Genetics and Genomics, the link to which is provided on the website. And FORCE is a hereditary cancer center organization that actually offers a toll-free helpline with volunteers who are board-certified genetic counselors who can help you find genetics expertise in your area to ensure you can have that proper counseling and conversation, because getting that report back can be challenging, whether it be a genetic or a genomic test, but having your clinical care team involved in interpreting that, I think, is a really crucial step. Last but not least, where does this land in the field of research? We have a study specifically looking at those two last questions and understanding what are there new genetic changes that could be contributing to appendix cancer development, and also how are these changes reflected in the appendix cancer tumor. So the GAP study is open and enrolling individuals who've been diagnosed with appendix cancer across the United States and are at least 18 years of age. The QR code is there on the bottom of your screen, and also the website listed. We asked for a couple things if you choose to participate in the GAP study, some of which are optional. But most importantly, hopefully now that you've heard my talk, you can understand the provision of that small saliva sample is how we conduct a genetic test on the GAP study, and giving us permission to study some of the appendix tissue that was already removed helps us understand the genomic component, so we can really uniquely pair these together in a large patient population to drive clinically impactful results. We realize that sometimes single institution studies in a population for a rare cancer can be challenging. So partnering with patients and fantastic clinical colleagues is really a unique opportunity to drive a lot of research and paradigm shifting findings in this space. And I say all that to say we have a fantastic constellation of clinical partners and individuals who've shared the GAP study with their patients and are continuing to do so. GAP would not be possible without that collaboration and support, both with patients and with our clinical colleagues. Have to give a shout out to the ACPMP Research Foundation, who's been a champion in supporting GAP, helping us ensure we can reach a broad and diverse audience overall in that capacity. And I'm going to round out my talk with just a couple references in case you'd like some links to learn more about genetics or genomics or revisit things. And thank you so much for your time this morning/afternoon, depending on your time zone.
Great, thank you so much. It is really encouraging, and again, I think another just sign of how far we've come to actually have a PhD scientist involved and focused on appendiceal cancer and trying to bring together genomics and genetics. And one of the most common questions I think we get is, somebody in my family had appendix cancer. Should I have my appendix taken out, or should my children have it taken out? And I think a question still to be answered, but hopefully someday we will have that answer. I personally would love to have a whole day of prophylactic appendectomies and just do like 10 appendectomies and cure this problem. But
Andreana, I don't know if this is a good time for a question. I wanted to ask you a question, and maybe something you can answer for the patients. Can you speak a little bit about why the GAP study is helpful, and maybe insurance coverage for germline testing that patients might have to deal with if it's ordered off-label?
Yeah, so one of the things we actually say when patients email the GAP study, if you go to our website, we also have an email address and phone line that patients often reach out at, we send that copy of that JAMA oncology paper as often as possible in PDF to ensure there is no paywall, but often to say, utilize this publication or this research to support genetic testing coverage if your insurance company doesn't cover it. Really wanting to ensure for those reasons, could family members be affected? You know, Ben Franklin said, an ounce of prevention is a pound of cure. Can we identify where prevention and surveillance might be warranted in the context of family members? We know that when we typically identify somebody with Lynch syndrome, there's literature saying they typically have about 3 family members who also have Lynch syndrome. So there's a lot of consequences to that genetic test result, positive or negative, to understand disease risk, secondary cancer risk, which we don't really well understand yet in terms of the appendix cancer patient population, et cetera. But hopefully utilizing that JAMA Oncology publication and sharing that with a provider or genetic counselor to say, hey, if genetic testing is right for me, can we get insurance to cover it this way?
Great, thank you very much. We look forward to learning more from your research. And next up, we have Dr. Kostas Votanopoulos from the Atrium Health Wake Forest Baptist Medical Center. He is also a member of the ACPMP Scientific Advisory Board and one of the highest funded researchers in the area of appendiceal cancer. And he is going to speak to us today about organoids and personalized chemotherapy, another very common question. Is there a way that we can figure out which chemotherapy is going to work best for each individual person in treating their cancer? So Dr. Votanopoulos.
Well, thank you very much for the opportunity to present. This is probably one of our favorite events every year in October. These are my disclosures. And well, I mean, at the base of the entire talk is like CRS and HIPEC. And I don't need to explain to this group that why nobody likes to have a HIPEC, a CRS and HIPEC, because it's a 8 to 10 hour long operation. It comes with a 3% mortality. You have 40% morbidity. You have an ostomy rate of about 20%, up to 20%, and it drops the quality of life for 3 to 6 months. And because of all of that, we try to be as selective as possible. And quite often, as Andreana was saying, we try to see if we have a target in the tumor of the patient. And these data are from 2017, not for appendiceal cancer, but for all comers. And only 7.5% of the specimens were predictive of a clinical benefit. If we say that today is at 10%, we realize that 90% of the patients we won't have a target. That's why we start doing the organoids. And what is the organoid? We take an organoid is not more than a 3D reconstruction of the tumor. We take the tumor, we dissociate the tumor, we drop this tumor into a hydrogel, and then we test this tumor that functions like an avatar of the tumor of the patient outside the body and see what's going on with that structure. And how do they look? They look like this one here. This is an appendiceal cancer organoid that we built in 2017. Green is living cells and red are dead cells. And this is our current operation assembly line. In 2023, we have built more than 700 organoids from different specimens. The organoids are built within 24 hours because we don't expand any cells. And then within the next days, we do the chemosensitivity or immunosensitivity trials. And I have shown that before, but this is a good example of how a chemosensitivity trial works. A red cell means that the tumor is dying. So any drug that kills the tumor gives this red picture because red means dead cell. So for this patient, the best treatment is the last one that leaves less than 12% of the cells alive in the tumor. Furthermore, we had this idea of introducing the immune system within the organoid, and in this way, we can find out if immunotherapy is a possibility for that tumor or not. Now, why are we using organoids? We're using organoids for different reasons. One of the reasons we are using organoids for is to identify, to investigate new drug applications. This is when you start treating organoids with bromelain or seeing what bromelain is doing at the mucin of the patient. What you see here is that after about a couple of hours to 3 hours of bromelain, the majority of the mucin goes away. So naturally, the next question was, what's going to happen if we treat cells with mucin, with bromelain, not only mucin. And it seems that if you treat appendiceal cancer with bromelain, you kill about 30% of the cells from the organoids within about an hour. So the question is, can we use that in a combined way of doing a HIPEC with a part of HIPEC being a bromelain and a part of HIPEC being chemotherapy? We don't know yet. We are generating the preliminary data. Another reason we're using organoids is to find out what about the classical chemotherapy regimens that medical oncologists are treating the patients with. What you see on the right side, you see that what looks like a wall is no response to any of the low-grade appendiceal cancers that were treated with chemotherapy. Everything stays at 100%. And what you see on the left side, you see a number of high-grade appendiceal cancer where the chemotherapy may have some activity, but the activity is variable depending on who is the patient and what is the tumor. We can also use organoids to find out what is going with immunotherapy, if immunotherapy is an option. These are the only preclinical data on appendiceal cancer and immunotherapy. It seems that immunotherapy may be working in less than 20% of the patients. And again, it's highly variable on the tumor and the individual patient. We also use organoids to see why we had the results we have with a clinical trial. What you see here is the Wake Forest clinical trial on appendiceal cancer, oxaliplatin versus mitomycin C. And what this trial showed, it showed that both drugs were equally efficient. And if you see that, you don't really know if both drugs are doing something or both drugs doing nothing, right? But when we tested organoids with these regimens, in brackets, you see that for a low-grade appendiceal cancer, after 2 hours of chemoperfusion with mitomycin C, about 18% of the cells stay alive. And when you do the same thing with oxaliplatin, about 19% of the cells stay alive. So indeed, the two drugs were equal. Furthermore, why we do heated chemotherapy for everybody? Why not simple chemotherapy, not warm chemotherapy? In reality, mitomycin C has a good activity without hyperthermia. And that's why they're using mitomycin C in BiPAC. In about 23-24% of the patients, adding heat for the chemotherapy really doesn't change the killing capacity of the chemotherapy itself. And why you think all the above are important? It is important because at some point we'll be able to test both intraperitoneal concentrations of chemotherapy and systemic concentrations of chemotherapy and identify what drug is best for every individual patient. So what you see on the left side, you see that for that specific tumor, at systemic concentrations, what the tumor is seeing through the bloodstream, none of these drugs is effective. On the other side, though, if you take oxaliplatin and you heat the oxaliplatin and give intraperitoneal concentrations, this oxaliplatin for the same tumor becomes a very effective treatment. So why do we fail? We fail because of that. We fail because when we open an abdomen with that amount of disease, you don't get one tumor within the peritoneal cavity. You get many, many different tumors that coexist within the same patient. And why do we know that? We know that because we have done the genetic analysis of these tumors. And the different colors here represent the different genetic makeup of different tumors within the same abdomen of the same patient. And how bad is that problem? It's quite significant. When we try to generate an appendiceal cancer cell line out of 1 centimeter of tumor, we generated 8 appendiceal cancer cell lines. And why this is a problem? It is a problem because if you grow these tumors from the same patient at the same time in parallel, and you treat them, all of them with the same drug, every single tumor responds in a different way. So you end up with a situation that whatever is going to die in terms of tumor cells will die, and then whatever is resistant will take over and will expand within the peritoneal cavity. So if we want to address that problem, if we want to address the problem of clonality within the same patient, we need to be able to know how many clones we have within each individual patient. We need to be able to know what is the relative volume of each clone within the abdomen, which clone is the most aggressive, and what is the sensitivity of each clone to the different drugs. And today we cannot do that. We don't have this information. So the solution we had to that problem for us and what we are working on right now is we create to activate the immune system of the patient to identify the different clones. So we create what we call the organoid interacting lymphocytes, the oils. What you see here is you see this structure where you have inflow and outflow cannulas. You take the tumor and you take the tumor along with the immune system for the patient. You put it in these small wells within the plate. And then you take the peripheral blood of the patient, you circulate the peripheral blood through these structures. And days later, you have a T cell population that is coming from the patient that can potentially recognize these different antigens. And what I'm showing here is the first data that demonstrates that these oils have activity against appendiceal cancer. The arrows demonstrate how the T cells that we have trained encircle the tumor cells. And this is at 24 hours. So we co-culture the T cells that we have generated, the oils with the tumor, and you see how the tumor is getting encircled by the T cells. And 72 hours later, those cells are not there anymore, are dead. So I would like to show you a video. This is not an appendiceal cancer, but this is what we're trying to accomplish here. On the left side, you have the control. It's a tumor with the untrained peripheral blood of the patient. And on the right side of the screen, you have the tumor with the T cells who have been trained to identify the tumor. And when the T cell identifies the tumor, what's happening is the T cells multiply and they attack and they're killing the individual tumor cells. I don't know why we cannot play that video. How can we play this video? I wonder.
I'll let you.
Well, apparently we cannot play this video. Sorry, I don't think we can demonstrate that, but if you, whatever you would be able to see, you know.
Oh, Dr. Votanopoulos, I think you're muted now. Yeah.
Yeah, we're trying to play the video. I'm sorry.
Okay.
No. Okay, so I'm really sorry, I cannot demonstrate that, but if we could, you would see that this tumor stays alive here, and that tumor over there is getting eliminated by the T cells. That would be my last slide. And I would like to thank our lab. I mean, it takes a village to do all this kind of stuff, but it's a big team, and I would like to say a big thank you to all of them. And if you want to read more about us, this is our website, and I will take any questions you have. Thank you.
Great, thank you. That was a terrific overview. Looking and exciting research and promising. We look forward to seeing more results from that. So thank you. I guess we're now at the time for Q&A, and there has been a number of questions posted in the live Q&A that I'm going to try to see if we can go over some of those. Unfortunately, a lot of them were directed to Dr. Shen, who I don't think is on the symposium at this time. But we can try to go through some of them and see if some of the rest of us can answer some of these questions for you. So one question was, Dr. Shen had mentioned that CT scans don't tend to pick up mucinous tumors well. And the question is, what other imaging or diagnostic options are there? I'm going to throw that out to either Dr. Turaga or Dr. Votanopoulos and your thoughts on imaging for mucinous tumors, CT scans, PET scans, MRIs. What do you guys think about those?
Yeah, so I mean, go ahead, Kiran. Go ahead.
No, Kostas, you go ahead.
So it's for a CAT scan, anything that's less than a few millimeters, it cannot be picked up. So the reason we're using a CAT scan or any imaging, for a low-grade appendiceal cancer is to identify a reason not to operate, and in these cases, I mean, if you cannot see it, probably for a low-grade appendiceal cancer. Given the indolent course of the disease, I think that's all you need. Yes, we do realize it's not accurate. I mean, the significance is when you try to decide who's going to go to the operating room, and in this case, you know that you're going to find more than what you're going to see on the CAT scan. But for surveillance, I think it's a pretty good instrument. It's not perfect, but we get the information we need.
I mean, I think a couple of caveats that I'd like to add to that is that, PET scans are actually very difficult to interpret in the setting of mucinous disease because mucin by itself doesn't light up. So generally, they're not very good for mucinous tumors, and we don't normally recommend them. There have been some groups that have found that the FDG PETs do have something called a negative predictive value. So if they're actually positive when you have a mucinous tumor, that it's actually a bad sign. So sometimes people use PET scans like that, but they're not very good for mucinous tumors. MRIs can be, quite good if done in the right way with the right protocols, but they are time consuming and they do take, expertise to do it. But I think if you have the right sort of group and team, I think MRIs can be a good way of also imaging mucinous disease.
Yeah, that's the way I approach it too. I rely so heavily on the CT scan. I think it's the best modality, but of course I'm better at reading those than MRIs. The MRIs do require a specific protocol and really good expert MRI readers. And the same thing, Kiran, I feel the same way about PET scans. They're just not as reliable, and they're not great for surgical planning. You don't get the detail that you usually get with a CT scan. So that's good. That's something we all seem to agree on. And then Dr. Votanopoulos, there's a question. Is organoid analysis available for individual patients?
Yes. Well, we don't share the results with the patient, but we do share the results with the treating physician. We don't make right now decisions based on the organoid results, but they're available for consultation.
Okay, great. Let's see here. Does anybody have any thoughts on, so this is I don't know, I do not have an answer for this one, using EpCAM, epithelial adhesion molecule targeted agents, or using Lonsurf with bevacizumab for PMP. Thoughts or comments on that?
I think Mike Foot's going to be on later, so maybe we can ask him as well. Okay. I think the EpCAM antibody, was done as a trial with Fresenius Biotech a while back, and there actually was a positive trial for malignant ascites and reducing puncture-free survival. But then the company was discontinued, and so now there's new EpCAM antibodies that are coming out. So I think it's hard to know how well to use it for appendix cancer, and I've certainly not used it for my population. We've certainly used Lonsurf and bevacizumab in a few patients. I don't think it gives dramatic responses, but it does help when patients have ascites, anecdotally. But I think it'd be nice to ask Dr. Foot. I don't know, Kostas, if you have thoughts.
No, I've seen Lonsurf, but it's like some patients do have remarkable responses, but some others, they progress quickly. So it's hard to say. Yeah.
A question, I think, for Dr. Holowatyj, there was a question in there about being eligible for the GAP trial. I think you may have answered it. Did that sound familiar? Yes. A laminin tumor that did not fully rupture or spread to the peritoneal cavity. Is that person still a candidate for the GAP study? And you said yes, but maybe if you want to talk a little bit more about that.
Yeah, our enrollment criteria is broad. We actually even include patients with NETs to make sure we don't exclude anybody. We're hopeful to ensure diverse histological subtypes of appendix cancer, as has been spoken about throughout the day. I think there's a unique ability to do histology-specific studies on the biology and the genetics, and that would be incredibly informative. So as long as, and I know this is a little bit controversial, but due to sample shipment, whatnot, need to be diagnosed in the United States at present to be with appendix cancer to be eligible for GAP, but Lamin and Hammond cases are eligible.
Great. Great. I was going to try to pull up the questions here again. Let's see. We're going to hear from Dr. Flatmark about her vaccine, and we talked about Bromac. Does anybody know, maybe Dr. Turaga, research protocols, clinical trials ongoing for SMAD4 mutations? Did you come across that in your review?
No, I wasn't specifically looking for that. And I don't know if it's druggable, actually. I don't know if there's drugs right now for SMAD4.
We did identify a germline SMAD4 mutation in that JAMA Oncology paper, so I do think there's some potential interest there.
Great, good. So stay tuned. Excellent. There were a number of questions that came up about intermediate or moderately differentiated adenocarcinomas of the appendix, and people were asking where do they fall in that spectrum, and how do we approach them? Are they approached more like a low-grade tumor or a high-grade tumor? Maybe Dr. Votanopoulos, how do you handle it?
Yeah, we approach them as high-grade tumors. So the moderately differentiated goes for upfront chemotherapy, and then they go for HIPEC if we can set a register.
Okay. And Dr. Turaga?
I think it's a little bit more nuanced approach with us when we're thinking about moderately differentiated adenocarcinomas. So one thing that we're working on trying to figure out is, what do you do if someone has a moderately differentiated adenocarcinoma of the appendix, but the peritoneal disease is very low grade? So it's very mucin dominant. There's hardly any cells in it. So those patients, do they act more? And we're talking just about patients with peritoneal disease, but those patients are a little bit, they act closer to the grade 1 PMPs. I tend to use systemic chemotherapy like Kostas mentioned, thinking of them more like grade 3 tumors. But I think there is a distinct morphology of moderately differentiated where, they don't need the systemic chemotherapy and they actually do very well. We've also found that when we check ctDNA for some of these folks, for the low grades, you absolutely should have almost no ctDNA in the blood. So you have no Signatera signal for a lot of the low grades. And for the high grades, you see some signal depending on what it is. It's the moderately differentiated. It's when we see a positive ctDNA, I treat them a lot more like a grade 3 or high grade cancer. And if it's negative, then depending on the clinical picture, I'll either treat them more like a grade 1 or grade 3.
Mm-hmm.
Yeah, I would like to echo that. I think the biggest problem is what Kiran said. There's no really a good way to know what part of the tumor is going to be high grade or low grade. And usually what's happening is the peritoneal disease is going to be higher grade than what it is the appendiceal disease. It's very difficult. It's very rare to find the opposite, to have to go from a high grade to go to a low grade. Usually it's the other way around. It goes from a low grade to high grade. Mm-hmm. So that the chemotherapy will not do anything for the low-grade disease, but you're trying to target all the high-grade component, because that's going to be what will determine the survival of the patient, not the low-grade component.
Mm-hmm. Yeah, so there's still a ways to go in our understanding and management of these complex tumors. One more question: is anybody aware of a relationship with BRCA2 germline mutations and appendix cancer, and is there any role for PARP inhibitors in this setting?
Yeah, I can't speak to that quite yet. I know we have some data looking at that, but I can't, it's not at a spoiler alert moment quite yet. So we are actively, and I can't speak to the PARP inhibitor, but we're actively investigating BRCA1, 2, as well as other potential genes for cancer susceptibility at the moment.
You know, we have seen BRCA2 germline with appendix tumors, so I'm sure Andreana is unable to share her research and data yet, but I have certainly seen that in patients. And Andy Lowy actually, I think, published a small paper, if I'm not mistaken, on PARP inhibition for patients with unresectable mucinous disease, and at least anecdotally, he thought he had a good response. So we've actually treated, I think, one patient off-label with PARP inhibition, and anecdotally, the patient did okay with stable disease, not a good response, but I think more to be investigated. But I don't know, Kostas, if you have explored that.
Very, very rare, almost unknown data.
Mm-hmm. Yeah. Great. I think we are at the time that we were allotted. And so, Deborah, I'll turn the time back over to you.
Great. Thank you, Dr. Lambert. You are keeping the train on time today.
Well, all the stuff. Thank you to all the speakers for doing that.
Absolutely. Thank you all. That was a terrific series of presentations. I'm sure everybody's mind is chock full. So let's take a brief break, a 10-minute break or so. We'll reconvene at 2:35 Eastern, and we'll get into our last general session, part 3. We're going to have Dr. Turaga moderate that. And that is really a very interesting summary of our 2023 Research Grant Awards and where we're at with that. We've got Dr. Foote presenting, as Dr. Turaga and others have mentioned. We've got Dr. Flatmark's presentation on the GNAS mutation, and we're going to hear a little bit about radiotherapy and some work that our recipient of our Young Investigator Award for appendix cancer is doing. So see you all back at 2:35. Thank you.